Okay, thank you. To the Minister of Health, and he is responsible to appoint the chairman and the members of the committee with the reporter of the committee. Committee usually comprise of 12 to 16 members, and they are mainly professional, including highly qualified doctors and pharmacists from the Minister of Health, Higher Education, and Scientific Research. And the reporter will be an experienced pharmacist exclusively selected from the ministry. The pharmacists represent at least 1/3 of the total membership. The remaining members will be specialized doctor, ensuring advisor and knowledge committee. الآن هي حقيقة الآن هي بحدود 15 عضو. 3 فقط هم صيادلة، وال12 المتبقين هم كلهم أطباء من اختصاصات مختلفة حسب نوع الاختصاص والحاجة للأدوية المطلوبة. Approval, they eliminate the responsibility of the committee, approval of effective pharmaceutical and therapeutic supplies for circulation in governmental and the private sector, and eliminate those with safety concern. Then separate the medication list into private and public. By the way, بالعراق احنا عندنا قائمتين, 2 lists, راح نشوفها. One we call it for public, which is used in the hospitals, okay, governmental hospitals, and the other for private use, contain the drug of the private use. Monitoring the post-marketing outcome of all novel and biosimilar treatment, facilitate communication between technical and regulatory bodies within the Iraqi Minister of Health. The committee responsible for conduct a comprehensive review of the treatment guidelines currently established in Iraq, identify the separated scientific practice and workshop and that address emerging needs in the field, establish subcommittees to monitor, investigate, and evaluate the treatment protocols. The national enlist evolution, the process, in December 28, the drug list, separated into 2 lists, comprehensive and essential. As I said, the essential list is mainly for the government, hospitals, and it should be supplied free, no charge for these drugs to the patients, okay? And it was prepared by Kimadia, we call it Kimadia, a company in الشركة العامة للدوائية في وزارة الصحة. In 29, the list regulated imported medicine have been upgraded to include additional new medication. And the basis in February 2016, the basic list was approved with 3 levels. بهذه السنة 2016 ال2 list اللي احنا قلنا essential and comprehensive قسمت إلى 3 ليفلات, 3 levels. We call it level A, B, C لتوفير الدواء. level A يشترى من قبل كيماديا، وليفل B أيضا يشترى من قبل كيماديا حسب الحاجة، ويشترى من قبل المستشفيات level C. يعني كيماديا ما تشتري هذه الأدوية، وإنما هي المستشفيات حسب التخصص المستشفى هي اللي تشتري الأدوية، لأنه مو كل الأدوية تستخدم من جميع المستشفيات. وبنفس الوقت يعني حقيقة هي كان أيضا ظرف اقتصادي بسبب داعش في وقتها، فصار نوع من أنواع الترشيد الاستخدام لقلة الموازنة. في نوفمبر 2022 the comprehensive list has been updated. احنا كل سنة تقريبا اكو تحديث في القائمة، ودائما اكو اضافة. يعني الان في 2024 انا دا اتكلم mainly on the list essential list، تقريبا انضافت بحدود 50 إلى 60 item. وكل هذه الايتم it is in new drugs, especially in the oncology, in the MS, hematology, and so on. يعني كل هالأدوية اللي هي updated. دائما احنا حتى في الدايابيتس يعني دائما احنا عندنا أدوية حديثة ومكلفة، ولذلك العقود الآن تصل قد يكون دراج واحد يأخذ عقد بحدود $50 مليون. it is costly actually. 2022 شوية تحسنت الأمور، وبالتالي رجعنا again to the two list, mainly two lists. The level system in the old basic list has been cancelled and a single basic list has been adopted to be imported. هنا نقصد بها the essential. يعني return back to the essential and comprehensive. الشاملة for private sectors, in the private hospital, private pharmacies, okay? But the essential is for public. List of eliminate governing rules, adoption of international recognized international certificate, the most important of global example, FDA. These are the basic thing when we decide to select a drug. We depend on these informations. FDA, EMA, TGA, WHO, in addition to the pharmacopoeia and other approved references. Again, consider taking into account studies on the effectiveness and safety of the treatment, the inpatient needs, and the requirements of health institution for a proposed treatment must be assessed and considering treatment cost and the economic viability of materials. Consider the opinion of advisory committee and special centers, withhold discussion with them, offering alternative treatment at better prices with similar effectiveness, examining the treatment options available in international and neighborhood countries. هذه كلها تؤخذ بنظر الاعتبار when we want to select a drug to be in the list, especially the essential list. We have to keep in our mind all these factors in order to select such a new drug and add it to the system. The policy is an important economic outcome for the Iraqi MOH. The fundamental principle is to adopt economic analysis and engage in a price competition and to achieve optimal therapeutic outcome with the maintaining minimal cost. الآن احنا يعني قبل كان حقيقة الكوميتي كانت مسؤولة فقط for selection. الآن احنا دخلنا the price with the selection. So we are going to depend on the pharmacoeconomic study in order to select the drug with the price, and we put a lot of pressure on the company in order to reduce the price, especially for the new drugs. The approval of various biosimilar at different concentration has significantly lowered the treatment cost of cancer, rare disease, and the blood disorder while maintaining the same therapeutic effectiveness. الآن احنا دخلنا قررنا البايوسيميلرز، أثر على الكوست، نزل الكوست تقريبا almost 40% of the drug. يعني احنا ما اريد اجيب اسماء ادويه والشركات، ولكن كانت الامبوله الفيال الواحده في احدى الادويه تنباع الفيال الواحده هي بحدود $2200 by this biosimilar, and the pressure نزلت إلى $1400. We save a lot of money to put it on another drugs, import another drugs. Adopting the principle of approval within the lowest price rule has led to a huge reduction in the cost of treatment. لأنه إحنا الآن في القائمة الأساسية essential في القائمة الأساسية حقيقة تحتوي على بحدود 650 دواء. هذا هاي 650 دواء القائمة الأساسية المسؤولة عنها كيماديا الشركة العامة للأدوية أن تستوردها وتوزع مجانا في جميع مستشفيات العراق، وكلها هي هذه طبعا مكلفة. الكلف مالتها هاي تقريبا الموازنة مالتها تطلع بحدود $1,200 مليون، لا $1,300 مليون. هذه كلها توزع. فاحنا نتكلم mainly on this. البرايفت يعني احنا من نقر هذه للصيدليات الخاصة والمستشفيات الخاصة. adopting the principle of approval within the lowest price, implementing strict scientific standard for approving blood factors for major international companies and the new plasma-derived formula. قبل كان فقط بالنسبة للفاكتورز mainly we depends on the recombinant. Now دخلنا أيضا الهيومن اللي هو كان عليه question mark. Okay, I will finish. Okay, now the blood factors. So it will reduce matching company for free goods at varying rates based, and they also support the localization of pharmaceutical industry. And the decision shall be made through a voting process. The view of each member of the national committee will be associated. In the case of tie or opinion, chairman of the committee will prevail. Should not be possible to reach a conclusive decision. Let's go with this one. This is the last slide. For the future, establishing health, we depend on the technology assessment, pharmacoeconomic and cost-effectiveness balance for approval, updating medicine in public health and popular medical clinic to align with the global guidelines for communicable and non-communicable disease, rare disease, regular update medicine list for all public and private healthcare sectors as needed, and recommend establishing specialized medical committee to hold scientific lecture.
Thank you very much. I think we 1 minute finish.
This is the last. I said this is the last slide. So I completed. Reinforce their methodology for evaluating modern medication, and finally engage national factory owners in meetings with the national committee to tackle factory challenge and enhance the national pharmaceutical industry. Okay, thank you very much.
I'm a consultant in pharmacist, and it's been my great pleasure to introduce the second speaker, Professor Dr. Safwan Taha. Dr. Safwan Taha is Professor of Surgery, consultant laparoscopic, metabolic and bariatric surgeon, and Director for Bariatric. He's a fellow of the American College of Surgeons, and he's currently working in the medical airport children's hospital over there. He will also talk about obesity, what, why, when, and how pharmaceutical aspects.
Thank you very much, Mr. Chairman. Assalamu alaikum jami'an. First, I stand with thanks to the organizing committee, Mr. Manaf, principally for the journalist invitation and giving me this opportunity to share some of my experience with radio and some friend that didn't see me before. So thank you very much. So it was really difficult to talk about a very specific specialty to fellow physicians. So I tried to make it less than in that is what I would kind of understand. Right. So yeah, like we used to post in your email, always people like lateral people. That's really odd. People who really like jokes, they make jokes, they're not smart, but a reason itself is much about not as used. It's really a very dangerous thing. And we need to take it seriously. I'm talking. Okay. So I got it. It's not matter cake. Not always working out as tight. And so let's go through that. This journeys with I'm going to introduce obesity. What's obesity? What are the definitions for it? And how we can manage it? Firstly, is that problem? It is a new problem, and it's only one number for an endless list of numbers. On the not problem because each word will make some sort of medical intervention to solve the ways the problem as in 100 millions. Suddenly, so into testing. First, where you are patient. Actually, it's every testing about surgery. That's what I'm talking today. There are more than that. It is a big problem, and it's increasing. To the point that college students take it as an epidemic now, just like Greenpeace. They want to save whales and underwear and species from extinction. we need also the same line kinetics for obesity because of becoming and an epidemic. Why are we so overweight? I think this is a very short summary of why we are overweight. It's possible to get it like that, but basically it's either consumption of foods of high in calories or consumption of a large amount of foods, just like you see in a minute.
Or not burning calories, but most importantly, actually, is the last one. It's written here, inheriting fat genes, but it's actually, obesity is a disease. It's not a lifestyle issue, and I'll explain what in a minute, where all the first three factors are of secondary importance when you consider them to the etiology of obesity. This is roughly the size of a hamburger and French fries in the 60s. And this is the size now. And you can tell the difference. Actually, when it comes to soft drinks, the problem is even worse. You have large cups, then mega cups, then double mega cups. And people who live in the States, in North America, I'm sure they appreciate that. They just want to make you gulp as much as soft drinks as you can. But to solve a problem, we have first to recognize it. I mean, if you don't admit that you have a problem, you won't solve it. And it's not to my surprise, but my observation with my patients, when I ask them, you know, as you will know now, obesity as a disease is divided into three groups, subdivided. And I have patients who are way beyond the last group. And when I ask them, obesity is 3 levels, you know, depending on severity, which one you think you are? And the vast majority will say the second or the first, although they are way beyond the third. And that's a big issue. It's improving, thank God, for the past probably 5-6 years it's improving. But then first you have to recognize that you have a problem. And second, you have to do something about it. Not just like this guy who says that he just passed by the gym as the first step in managing his obesity. Oh, that's a rhetoric. Right, so who are the top fastest nations in the world according to the World Health Organization 2022? Here's the list. And the percentages are horrifying. Those are people who are more than 30 BMI. And I'll tell you what 30 BMI in a minute. It's horrifying. 70+% of them, those few nations, are more than 30%. As you can see, almost the first 20 nations, 5 of them are Arabs. Iraq comes 21st, surprisingly, which, although, I mean, despite the difficult circumstances, we're still the 21st fattest nation on earth. The Emirates come at the 45th place. It is a big problem even by Arab standards. And it's a complex disease. It's not just like because they eat more or they don't exercise or they have a family tendency. It's a combination of both, of all. So just having the tendency might not end up might end up causing you a disease, but it's a complex disease, and that's why it's managed by what we call a multidisciplinary team, as I'll also talk about it in a minute. So who are considered obese? I mean, in the 50s, the insurance companies came up with a scale just to insure lives, and they, you know, if you remember that, weight and height, and you have a line between them. If you are above that line or below that line, it doesn't work anymore. This is what we do nowadays. It's not the best, but it's the best that we have. It has its own deficiencies, but it's the most efficient way of assessing obesity that we have so far. It's called the body mass index. And somebody will say, all right, so why don't we talk about weight? Somebody is 120 kilograms weight. He has to be obese. No, he doesn't. Well, if you take any one of the NBA players, I mean, the average height is above 195 centimeters. They have, it's very ordinary to be 2 meters and 10. They are all above 110, 120, and they are normal. But if they're my height and it's 120, that's a big problem. So weight without the height is not the way that you assess your obesity. You have to have your weight and height. You put it in this equation. It's in kilograms, and the height is in meters, and you get your body mass index. And if you're 25, if you're between 19 and 25, then you qualify to be James Bond, if you're a man, or whichever model you like, ladies. because this is the ideal weight, a BMI, 1925. 96 to 29, 26 to 29 is what we call obese or socially. Overweight, we call them medically. They are not diseased, they are not ill, they don't have obesity, they don't need medication. All they need is lifestyle modification. But if you're 30 to 34.9, then you're class 1 obesity, and then class 2 obesity, and class 3, which is the highest level severe obesity. The slide says, lists the diseases that you can have with obesity. You don't have to see it. You don't have to see it because you name it, it's there. Nowadays, if you put obesity as one of the 5 leading causes of any illness in the world, nobody can tell you that you're wrong. So forget about lists. It's there everywhere. And numbers are frightening. I mean, this is one frightening number. Another number that I find even more threatening, if you take random population of people who are above 50 BMI and compare them to their peers who are below 40, who are still obese. They are class 2 obesity. But above 50 is a subgroup. We call them the super obese. And if you take them to their peers, they are males between 35 to 40. They have a sedentary job, live in town. They have married, have 3 kids. Everything is the same. Those are above 50, and those are below 40. The average lifespan is shorter by 15 years for those who are above 50. Horrifying, right? But this is data. This is statistically proven data. So it is really risky. And this graph tells you what's going to happen in 10 years. It's almost going to triple in the States. And it's double, 2.5 in other places. So it is a problem. It's a big problem. It's going to increase with time. And even if we do what we need to do, we aren't going to stop it, but probably you can reduce the progression. So we have medical management. We have a non-medical, non-surgical management. We have endoscopic management, and we have surgical management. And I'm not going to take you through the details because it's very specified, but I want to tell you something about so you can have a good idea about it. Medical, those are, the less important factors, which are the diet, exercise, and behavior modifications, as I said. So, I can't take much time, but flour, probably it's more damaging than sweets. Tahine, أي شيء بطحين, please don't eat it. And it has a lot of gluten. If you want to read about it, there's a great book called The Wheat Belly, كرش الطحين. It's in Magrudi and everywhere. You can have it online. It's a great book written by a cardiologist, and it tells you what's wrong. Because what happened is with wheat, we genetically modified wheat like for 50 years ago, 40 years ago, to have more grain and to make it more resistant to drought and heat. And the resultant thing is tahine, which is full of gluten. Gluten alters your liver function, and it will make it less efficient in burning calories. So even if you exercise a lot and you eat تشريب باقي للصبح, then بالدهن, forget about the 10 days that you exercise. Literally 10 days, right? Even بيض وطماطم مقلية الصبح أموت عليها أنا الخبز خلاص هذاك الأسبوع راح. So tahine and of course the sweets. Exercise, and the thing is, there's a big understatement of exercise.
3 minutes.
Exercise that makes you lose weight means that you have exercise 5 days a week, 45 minutes a day, and the last 25 minutes your pulse rate has to be above 110. If any of those 3, 5 days, 45 minutes, 110, 20 minutes, you are not going to burn calories. You are going to burn what you ate that day, but not what you stored. So you have to know that. Okay, I have to run here. They are running after me. Non-specific things. The anti-obesity medications, the last one, are important. They are hormones, GLP-1 analog, GLP-1, GLP-2 analogs. The first one is Ozempic. The second one is the very famous and notorious Mounjaro. I'm not going to talk about them. They are not always good. There are so many bad things about them. Please don't take them on your own. Let's forget, this is important, those are the balloons. So the non-surgical things are the balloons. Balloons, there are so many types, I don't have time to explain them. Balloons are only for low BMI. If your BMI above 33, forget about them. You are not going to lose a lot of weight. All the commercial websites say that they'll make you lose tons of kilograms, which is a big lie. It's 6 to 10 kilograms most, if you're lucky. And this is how we put it. We put it, inflate it, and take the scope out. And this, you have this balloon in your stomach for 4 to 6 months, depending on the type. Endoscopy, then, we do something close to surgery, but through the endoscope, it's called endoscopic sleeve gastroplasty, and it's very good for the proper patients. Those who have low BMI, high BMI, read that you can't do nothing about it other than surgery. Forget about that. Bariatric is a Latin term. Where it comes, I don't have time to talk about that. Who qualifies? Of course, besides being fat, you have to be sound. You have to sound mind. You have to be willing to follow a special diet or program or something. So you'll be seen by 8 consultants before you, and they all should give you a green bill before you go to surgery.
1 minute.
Yeah, I'm finishing, inshallah, hopefully. Finishing. So the surgical treatment, okay, forget about when it started. You shouldn't count this. It's not working. So I have extra time, right? It's not working. All right, so forget about that. Okay, so the types of surgery, they are the purely restrictive, just restriction. They don't do anything other than limiting the amount of food that you take. And there is the mostly restrictive, and there is the mostly malabsorptive that affect your absorption. So I'll show you examples very quickly. More extra time, Mr. Chairman. So, of course, we do that all laparoscopically. We don't open the abdomen. This is how we do sleeve. I actually do it in three openings, not 5. But this is the standard. And this is the band. It used to be very famous. Not anymore. We used to put 20% bands 12 years ago. Now it's less than 1 year. So I just won't put it here that you know it. We put a belt حزام على the top of the stomach, and we have a pump, a reservoir here, and we fill it to restrict it. I'm finishing very quickly. This is the most famous surgery, which is restrictive and malabsorptive, hormonal, not malabsorptive. Sleeve gastrectomy, قص المعدة, تكميم المعدة, حزاء, whatever you call it, تصغير المعدة. It's very famous, it's very effective, it's the widest applied because it is suitable for most patients. And then we have the gastric plication that nobody does anymore. We are doing that now, the endoscopy. We plicate the stomach, نخبنها بالعراقي احنا نقول, from the outside through laparoscopes ونصغرها.
30 extras.
Yeah, I have one last slide and that's it. So, and that one is the other very famous, the gastric bypass, where we divert food from the stomach. So we bypass تحويلة like 1 meter to 2 meters, and you get a calculated malabsorption. This is the Roux-en-Y gastric bypass, the oldest, and this is the OAGB, the mini gastric bypass, relatively new, like 30 years now. There are certain indication for those are operations that we don't do very rarely. They are purely malabsorptive, and they have so many complications. But the most important thing is you have to recognize that you have a problem, and you have to start working on it to solve it. Thank you very much.
Shukran jazilan, Ani, to give me this opportunity to present today. It was definitely a pleasure to come to my second country after Iraq, which is Dubai. So many, many thanks for that. Many thanks to give me the chance to present my my love in bariatric surgery, which is bariatric tourism. Not because specifically I love it, because I live in London, in a central hospital in London, which is literally about a direct line from Heathrow Airport. So any problems come from Heathrow, they come to me, unfortunately. Nothing to disclose. And this is what I'm doing most recently. More revisions. Yeah. So what is medical tourism? So medical tourism, literally, the patients do their operation outside the original countries. And the main attraction for that in UK is the low cost. If you want to do it privately in UK, it's very expensive. And the other attraction is the long waiting time in the UK to do the operation. So my waiting list on the National Health Service is 3 years for the patient to have the operation under me, if they want to have it under me. This is the last published. I mean, how big is this problem? What are we talking about? So in UK, we do about 10,000, our 10,000 patients seek weight loss surgery in UK. 5,000 of them, they do it outside UK. Now, this is only the tip of this iceberg. So if you can imagine, if each year we do 5,000 cases outside UK, we're doing bariatric surgery for the last 20 years, so we're talking about 150,000 patients we have in UK now as a result of bariatric tourism. So it's a massive problem, really. Is it an attractive business? We're talking about 400 billion, not million, 400 billion these countries are gaining from bariatric tourism. So it's a massive industry, yeah? We're talking about airlines, we're talking about medical indemnity funds, we're talking about travel agencies. It's the whole country economy based on that. This type of economy is equal to maybe 3 or 4 countries in the gross national income for 3 or 4 countries in Africa, for example. So it's a massive. From the patient's point of view, and instead of doing the operation in the US, and that can cost them £18,000, or on us, in London, it can cost them £15,000, they go and do it in Eastern Europe. It costs them £3,000 or less, even less. So that's the attraction for the patients. That's the trap for the patients. Now, is that available? Is that easily available? Just before I came to the conference, I just looked into Google. Just have a look at the Google. What's advertised in the UK? So this is advertised in the UK. So these 2 companies, I just blinded the names. I just removed the names from there. That's not the point here. But these 2 companies one of them going to come in January, and the other one going to come in February, and these companies are in the center of London, in Bayswater, in Harley Street. When you check on these doctors, when you have a look at these doctors, who's coming to give advice to patients, these doctors not even registered with the General Medical Council in the UK. Can you imagine? So they're going to give advice to patients for the major surgery. They're not registered like here in the Dubai Health Authority. Why? Because they're not providing the treatment inside the UK. So we don't have the law to stop them. Yeah? Make sense? Now, bariatric tourism, as we know, this is a massive talk, and I can't really address everything in this 12 minutes. But I'm going to show you the surgical point of view, the acute complication maybe, and the chronic complication, what I face in my hospital when I have problems with those patients when they come to UK. Fine, acute complication. Now, this is a 36-year-old lady, 36, yeah? She went to have her operation outside the country. They make the stomach smaller and they bypass the stomach, okay? So, it's standard for bariatric surgery. 3 days, she fly from that country to Heathrow. From Heathrow Airport, straight forward with an Uber, she came to my hospital. When I saw her, she was literally septic. Not even more that, it's a septic shock. Her pulse is 115. High temperature, high white cell count, high CRP. So straight forward to CT, and the CT showed a big mass in the left upper quadrant. So straight forward to theaters, and that's what we have looked in theaters. Now, when I went to theaters, I saw this big lump here. I didn't know what it is. Seriously, I don't know what it is. This lump was pressing on the liver, on the heart, on the top. Underneath is the pancreas, is the hepatic artery, is the aorta. On the other side is the spleen. And this lump is literally a necrotic lump. It's full of pus. I don't know what it is. And after a bit, I understand that this is actually the stomach that they divided and left it there. So they divide the stomach and left it there, and the patient flew from the country to UK. Now, the main problem here is not how to take it out. The problem here is this is stuck. This is an inflammatory mass stuck to the liver, to the pancreas, with the main part is the spleen. Look, I'm separating here from the spleen. And if that starts bleeding, what do? I have to take the spleen out. Anyway, that's the most important part, is separating it away. After that, everything was easier. I just suck it and took it out. But the main problem is separating this one out. It needs hands of God, as simple as that. So I was just lucky again, no more than that. So this is the first case. Second case. Now this is a 31. Look, have you seen these ages? 31, 36, that's the ages. So these are patients just that young. 31-year-old lady, 4 days after mini-gastric, but it's a major procedure. It's bigger than the first one, as big as the first one. Came to hospital, hemoglobin of 10, pulse 110. So I have some time to play with, so CT scan. And that's a CT scan. Look at the arrows. The arrow shows a gush of white. Can you see the arrows? It's a gush of white flow. This is the blood. This is bleeding. This is active bleeding. So this patient traveled with active bleeding. Can you imagine? How did she went through the airport and everything? Anyway, I'll explain that in a second. How did she do that? Have a look at this one. This is when I went inside. This big clot here blocking the bleeding, and that's what happened. That's why this patient managed to travel all the way, because this clot was like a tamponade. So she's not vomiting all the time. She bleeds into this clot, tamponading her, and after a bit she vomits. So when you wash this blood clot, you see the active bleeding there. See that? That's just behind the clot. Now to treat that, it's simple. The problem is just to get the patient to the right place. So what we do, we inject. There's a temporary treatment, and there's permanent treatment. So we need to temporize the bleeding until we manage to give it a permanent option. But the problem is, because it's moving, so it's difficult to temporize it. So we inject it with adrenaline, and you can see when the adrenaline is a vasoconstriction, it constricts the vessel. So you can see it's turning white here. Can you see the white on the top? So this is my needle going to inject it. And when this bleeding stops, I can then apply something stronger, like, for example, heating diathermy or a clotting powder. And you can see in a second that the bleeding will stop now temporarily by the injection of adrenaline, and they can apply the next step afterwards, which is the more permanent way to stop it. So you can see I'm going to push some water, and no bleeding comes into the water, and that means that's stopped, yeah? I'm just going to show you that in a second. That's the water, and you can see there's no blood comes into the water. So after that, you just put this powder, and this is a clotting powder, and that will stop everything. So again, both patients done very well. They literally discharged 48 hours after admitting to the hospital. We talk about acute, now this is chronic complication. Chronic complication means they come a bit late, like 7, 8 years after the operation. So first one, again, 48. This gentleman had a laparoscopic gastric plication. He had not lost any weight. Since the operation, he had not lost any weight. BMI is high. He's a big chap, so he's about 70, 160 kilograms, because he's tall and big. And obviously, he wants revision. So the problem here is the gastric plication is not an operation that's approved in UK, so we cannot do it in UK. So they have to go somewhere else to do it. And the reason it's not approved in UK, as Dr. Safwan said, is not suitable for everyone. Not everyone can have this operation. It has to be a certain suitable person. And it's a bit difficult to control that. So what we do with the plication, we literally fold the stomach walls, as you've seen here, and then we put these sutures. These are permanent sutures, yeah? Now, the problem if you want to revise this operation, by the way, this is the stomach after the operation. You can see it's massive, so of course you're not going to lose any weight. Now, if you want to revise this operation, the problem here is these sutures. These are permanent sutures. And if you fire your stapler against this suture, it will leak. Yeah? So then the patient will die. You have sepsis and die. So that's why the revision in such cases is really difficult. So obviously, the operation will last 1.5 hours. But for me to do this operation, I need another 2-3 hours to take these sutures out. Can you imagine? So I have to go through all the stomach from top to bottom, take all the sutures out, because if I leave it, what's happening is going to leak. Yeah? So I have to take all the sutures out. So can you imagine? 2 hours, I'm only doing charity work. So, but it's for the patient safety, by the way. Now have a look. Now you can see now the stomach is full, the bad part is separated, and we've done the bypass. Third case. So I know I'm being too illustrative here, but I think it's good to understand the problem really. There's a third lady. There's a 33-year-old lady. She's pregnant. She's not pregnant. She's a third trimester as well. So the problems with the patient and the child. Severe tummy pain. She went to Birmingham Hospital. I'm going to explain that in a second. She went to Birmingham. I'm in London. She stayed 4 days in the hospital. Yeah, 4 days. She's in pain, but all observation is normal. Bloods are normal. Everything is normal. For me, this is a straightforward case for internal hernia. I'll explain that in a second. But that's not the point. 4 days in Birmingham, no one does anything for her. She then traveled from Birmingham to London. From Birmingham to London, there may be 10 or 11 hospitals. All of them are equipped to deal with such patients. The patient said, no, I'm going to leave myself. Uber from Birmingham, she discharged herself, came to London. Fine. Now let me just explain what internal hernia means. Normal hernia is this on the left hole in the tummy wall through which bowel can go in and out, okay? When bowels go outside and it's stuck, obviously that can cause obstruction, can cause gangrene because the blood supply cut off. And it's easy to diagnose because you will see a patient with a big lump here. Very simple. Straightforward theater, sorted. Internal hernia happen between bowel loops. You will not see nothing. You only see a patient with pain with normal. She doesn't have bowel obstruction, doesn't have nothing.
3 minutes.
Thank you. That should be enough. So the problem here is we have to really deal quickly with this patient. It's already been wasted 4 times. The bowel might be already dead. So we have to take her quick to the hospital, quick to theater, sorry. So in theater, look at the fun. Gravid uterus. Now, the problem is this uterus is this big. Yeah? And if you can imagine, I need to push air inside the stomach so I can see. I'm not seeing anything. It's literally full. The stomach is full of this uterus. We operate on patients, as the surgeon here will know. We operate with the patient that way, yeah? So in order for me to operate on this patient, what I have to do is to put this patient 90 degrees up, yeah? So I can disimpact the uterus, the gynecologist. Disimpact the uterus from the bowel, so I can deal with the patient. So I cannot see the bowel. And even that, after I did that, what I found here is really difficult to pull the bowel up. It's very, very difficult because still the uterus is massive. So anyway, this is the ileocecal part, and this is me trying to hold the small bowel and pull it out. And you can see, I can easily perforate that. Again, just by God's will, I managed to survive. And the patient and the baby, obviously. So the first thing is to pull the bowel out from the hole. Remember the hernia, that means it's a hole through which the bowel is going to go there. So the first thing is to pull all this bowel out. And this is not like a small little lump there. In that hernia, all these loops are inside this hole. We're talking about 2.5 meters of small bowel. If this died, the baby will die and the patient will die. Yeah? If this is gangrenous, both will die. I'm going to show you in a second the hole. So just bear with me so you can see it. So this is me pulling the bowel loops, and this is the hole. Can you see it, guys? This is the hole. And this is now the hole closed. Yeah? Make sense? Everyone? Patient did very well. She discharged the second day after the operation. We have to keep it 24 hours just for the sake of baby's health and everything.
1 minute.
Yeah, thank you. That should be fine. She was so thankful. So after 3 months, she sent me this. Yeah, that was really the best thing I could put in my revalidation, isn't it? Fine. 1 or 2 things to mention. Why the surgeons are so reluctant in taking such patients? Why is that? Because the cost implication for this operation to happen in my hospital, £100,000. Yeah? Because multi-specialty are going to deal with this patient, not only one person. We're not sure what's happened inside. We don't know. We don't have a record of that patient's operation. We don't know what's happened. It could. So literally, I have the operation note, if I'm lucky, and the operation note is different language. Not in English, not in Arabic, a different language. Not only that, treating such complication is really hard. It's very difficult. You need plenty of skills. So, why should I put myself into it? And the main thing, if this lady or the child, something had happened to it, it's going to be on my record. It's going to be on my Ali Al-Hamdani national database because I've done the operation. I'm going to stop here, and I'm just going to say there is no international guidelines for, actually there is international guidance for bariatric tourism. The problem is that who can follow these guidelines? 400 billion pounds they take per year. And these patients are vulnerable. Why? Because they're waiting all their life. They are depressed. They want something to happen for them. And this company use and abuse them. So the whole point here, we need to protect our patients. Thanks a lot for listening. Sorry.
Thank you very much, the lead to the investment and subsequently the volumes. Cases now I person used to matter the trouble. The Somalians, the field professor of medicine and senior consultant and telemedicine that is still in college. In this kind of for the physicians and professor of medicine university universities. He going to talk about that is advancement in the era of artificial intelligence.
Dr. thank you for realizing communities and communities on the touch to the finding. and what the one that we just have to highlight, like one of what the that artificial intelligence and healthcare become one of the begin that education that which all should go with. And then we try to spot the light about diabetic care with you. What's the utility which was actually? So I think they should look pretty this. Zoom, good. Well, so this is why it's Claudia. And they did is go to the application of artificial intelligence, the prediction and the prevention of diabetes, and they would find a risk factor for diabetes, application of screening and the justification of diabetes, in anticipating complication of diabetes, and also the application of challenges of artificial intelligence. So about the prediction and prevention of diabetes, that part for the predictive therapy is the accuracy which we define with the and the proper use of the body that the patient is equipped with records probably whatever is the patient that prediction to develop diabetes in the future. And usually they use some statistical method, but now the machine learning will change, and it is promising that's able to diagnose future diabetes with an curve prescription point A. And also using the deep learning will facilitate also the diagnosis of future type of diabetes. But this, they will define the risk factor for future development of diabetes. Now with this, yes, the artificial intelligence will be employed in time risk factor for diabetes what is it, and also with the new implementation to predict this, and this is based on the organizable to be part of the startup. Besides intervention can be done early before specific one type 2 diabetes, before that the cases that need diabetic for a few years before diagnosis. And with this start, we should make it stable. We can stay to say that this is a recognized modifiable risk factor. So the patient has the risk pressure, high cholesterol, the glycemic weight, all substances, gap, typically, poor diet, poor weight, activity, all have the chance to develop type 2 diabetes more than the general population. What about the classification of diabetes? To admit that the current diagnostic guidelines of diabetes are usually certain by doing this as in this procedure, considering that any state of type 2 diabetes is symptomless, so probably using the artificial intelligence to predict the early classification will be helpful. The late stage diagnosis can lead to less complication and lower life expectancy, and it is not surprising that patient with diagnosis of type 2 got some of the complications already. I took the various pattern of the sector of vitalize with all type 2 diabetes and attempting to develop the accurate diagnostic method readily available with the patient data in advance with inexpensive tests. Three limitations, distant question are motivated to use of AI-based diagnostic that are the classification conspiracy, and this would help diagnose the patient with type 1, patient with type 2, and patient with gestational diabetes with protected to develop type 2 diabetes in this future. But for screening for diabetes, this is also a lot of problems now develop a wide range of sensing technology and integration of the associated database contributing to basic awareness of the artificial intelligence screening of diabetes. And with this certain-based diabetes risk prediction model based on features of the face or looking for the characteristic of the tongue, may be able to predict the future development of diabetes up to point A. Surprising to probably clear a few years back, we imagined that this is probably something like not real. The application also in the comprehensive management of diabetes. We know management of diabetes, it's constitute part of lifestyle in addition to that medication and health care. And now the artificial intelligence will help us in a health education. That is, many that help the patient to tailor the health education into suit his age, his physical activity, his limitation, and will bring without the time for the care provider is limited to give all these facility for education, and some probably in healthcare, dietitian is still not covered, physical activity is still not covered. So this will help the patient to tailor health education. Also, the making of the nutrition setup, the AI-based automatic diet monitoring. We know the patient they mention I must eat, I live what I have, but there is no actual calculation of the calorie which is needed, especially for patients that diaper is inject insulin. Now there is many that from the picture of your food able to tailor how many calories and also help the patients to plan his diet with the help of the technology. Proper diet is very important. With this, the diet recommendation system for patients with diabetes should be based on their knowledge of clinical nutrition, considering their eating, because the same food will not cause the same elevation of blood glucose in all patients. So this app will help the patient to tailor exactly what the nutrition is needed for each patient. Yes, and this is especially for those patients with either hypoglycemia or hypoglycemia, so the app will help them probably more than we as care provider who usually see the patient every 2 doses one. Physical activity is fundamental part of the dietetic care, and also there is many scientific, personalized and quantitative exercise program that can be correcting the patient to help them, to tailor his physical activity and how this impact upon his dietetic control and notification of his insulin injection or other medication. And probably we will bring one of these, artificial intelligence program for a private study in our university next one. And this would just to bring something, a program to develop in Canada to help, the engage our motivated patient for physical activity, nutrition, and the clients they have to control both their blood sugar as well as their weight. Blood glucose monitoring, many continuous glucose monitoring devices now available, and this is will help us to have an idea about the diet and weight that the doctor needs, the optimal time the blood sugar is there, and this is when we really checking the life of many patients who don't need enough the break to check the blood sugar. They have many sensors which develop the patient to achieve. This is all part of the technology. And some of these machines they have the data to predict the occurrence of event, especially the occurrence of hypoglycemia, which is about consequences on the patient outcome, both in mortality, morbidity, and mortality. And also, especially the adverse glycemic treatment, especially as mentioned with hypoglycemia. Yes, drug therapy, we know we have done with a lot of medication for patients with diabetes, and each medication would have an impact in the certain control, probably not all the medications fit for all patients. So now we have the optimal those strategy for many patients. There is many apps that remind the patient of their medication and also help them to monitor their blood sugar and lifestyle event, and we will usually facilitate the care provider for choosing the best second add to the current medication, taking in consideration the patient, the biodata from the patient, the electronic file, They have tendency for hyperglycemia, tendency for weight, battling exercise. So choose for the patient help us that this weight may be beneficial for this ad rather than from the second ad. Optimal strategy for the anti-diabetic drug also can be facilitated usually with the male treatments. There are being stage of dose is very important. Usually they remind us, they tell us that this treatment is not going to work. Unfortunately, we know this many patients can evidence be well just because the medication, and when we evaluate the file after 1 year, we see still an HbA1c not optimal. This is probably many reasons. Of course, it is not only the inertia from the care provider, the patient's adherence, the lifestyle. With this available, program with the patient, reminding them every day of his blood sugar, of his diet, with exercise, they show that it has significant impact in reducing the HbA1c and help the patient and the care provider to reach the goal. Application can be prediction, screening, and management of diabetic complication. And this is very important, and probably the best example is for the diagnosis of diabetic retinopathy. We know that, ophthalmologists is not available everywhere. Diabetes is studied globally everywhere. And now they teach some of the clever students or the teachers in the school just to get by the mobile, a fundus camera, and send this remotely to a center, medical center or diabetic center, and those patients which is suspected to have diabetic retinopathy, they have to be referred. So probably nowadays there was mass screening and essential complication of diabetes. Which is I also feel usually primary task for the medical psychologist is to control when we find this risk class up for developing complications. And I can find refer on this patient with severe complication as early as possible. All this technology help us that discover those patients which is with high tendency for complication and to be seen by specialists as early as possible. I don't know why CT will be management could be based on the prediction of diabetes complication and more convenient screening method, which is sometimes the patient don't have the chance to meet the specialized physician. So the picture of that, should we check several evaluations for the retinopathy, and also regulating vehicle use to the essence that progression of a chronic kidney disease. We know that retinopathy and retinopathy will go hand by hand, and also that tendency girls like since examination our species that well of patients with diabetes and the retina is a convenient window to that for your scarcity of the way so it is feasible for the regulation of such algorithm into diabetic retinopathy screening. That's the idea of taking how am I stick this? What is the opportunity they have on this? It is applicable. What diabetes is up there? That's the increased. That we between the practice of scientific care. This side I would be probably civilized more. We have many certain ways to get up to yes, but the science first application for the investigation, for the irrigation, the predictions associated, the opportunity. Probably with this we have helped to make a precision medicine penetration in the feasible settings, and also protection of the complication and also personalization of the lifestyle and the care. But of course, they say done, the technology was gone, the both technologies designed, the lack of data integration, the privacy concern, which is a concern very not realize, and also repercussion of laws and regulation. The problem that year after year, this is how the go to we been very severe that we can utilize every aspect of the patient electronic data, every aspect of the patient visit, every aspect of the patient history, the family history, the previous lab, and this with the help of the patient that probably we can transfer the management of type 2 diabetes and the future in a better way. So to summarize that, with reading the prevalence of diabetes, I can avoid like the morbidity and mortality due to diabetes and by difficulty to age, and relate with some associated economic burden make diabetes a significant health challenge worldwide. A shortage of diabetes specialists and even the distribution of medical resources local leads to limitation and counterpart self-management contribute to poor glycemic controlling patients with diabetes. And unfortunately, despite all of the indication and the still be controlled, the recent advancement in the digital health technology, special artificial intelligence, provide a significant opportunity to achieve better efficiency in diabetes care, which may diminish the decrease in diabetes-related health care in the state health, market reasonable progress in the education in the management of diabetes, open the opportunity of reputation in admitted practice hours medical care of coffee. Remember that these could be transferred in any aspect of patient diabetes and potential optimized diabetic care by providing personalized and precise data development support with patient identical professional and by addressing the challenges and detectorize the opportunity artificial intelligence to take place an important role in transforming diabetic care and improving the lives of millions of people with diabetes. And thank you very much.
That was the diabetes and as was time in like the only time for collections and activists because they found I don't know it's some you best at the game to they backing. It's the top. Yeah, how isn't it? Why they would yeah, as it's not involved. And some people not yeah, I did the comment and then you can run the right minute to so I love it. It's less you're thinking it's good with a view. It's just a place can be and first is yeah, interesting. I get out from there and there is I've got yeah, everything filled. Everybody. Right. Yeah, one, two, five. Say, I'm there, the bus with us lots of. It is a top. I'm going to listen to that, yeah. I'm going to but check that there's what is out there we were doing with the fact that this is 1% that's growing. So that's and there is